Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today I'm joined by two guests, Drs. David McIntosh and Bill Harrell. Dr. McIntosh is an ENT with a particular interest in pediatric otolaryngology, airway obstruction, and facial and dental development. He has over 30 years of experience in managing pediatric sleep-disordered breathing and is an adjunct associate professor of otolaryngology in Queensland and a fellow in the Royal Australian College of Surgeons. Dr. Harrell is an ABO certified orthodontist and pioneer in the areas of 3D imaging and dental sleep medicine. He practices in Alexander City and Auburn, Alabama, and also teaches part-time at the Orthodontic department at the University of Alabama, Birmingham. Both Drs. McIntosh and Harrell are return guests to the Doc Podcast, as each appeared individually on the show in the past. Dr. Harrell in episode 35 and Dr. McIntosh in episode 75. So I'll be sure to put the links to each of their episodes in the show notes so you can get a more detailed description of their respective backgrounds, as well as listen to the great discussions we had. But today, during this joint episode, we're going to do a deeper dive into the topics of evidence-based medicine, CBCT imaging, the impact of mouth breathing on facial growth, pediatric sleep-disordered breathing, and the impact we can have on craniofacial growth and development in young children. So without further ado, let's get on to today's episode with Drs. David McIntosh and Bill Harrell. Enjoy the show, everybody. Welcome to Doc Podcast, Bill and David.
Dave, thank you again.
Hey, how you doing?
Doing great. Thanks so much for coming back on. As I mentioned in the intro, you both are return guests to the show, but individually. So we'll have you here together for a really fun, interactive discussion that I'm really excited to have with both of you and be able to bounce some different ideas off you all so that the audience gets to hear the things that we talk about when we meet and brainstorm and have sort of closed door discussions on this. So we'll open it up and really lay some of the data and the facts out there to give people a little better idea on the different topics that I referenced in the intro. If people are interested, as I mentioned also in the introduction, of hearing more of their backgrounds and their stories of Drs. Harrell and McIntosh, please feel free. I'll put links in the show notes for today to click on that. So we're not going to go into their backgrounds because we've already done that. So we're going to jump right into the content. So to start off and put our feet to the fire right from the outset here, evidence-based medicine. This is something I've spoken on recently in my lecture at PANI a few weeks back. I spoke about this and I've been posting on it online. It's very poorly understood. Most people don't realize what it is. And there has been an overall effort by the establishment, I guess we could call it, to use that term and make us think that if there is not a randomized control trial, then we can't or shouldn't do things. And that is neither the intent of evidence-based medicine when Sackett developed the concept going back to the 70s, nor is it what is written down as it should be. So I'll start with David on this from the medical perspective, and then we'll go to Bill from the dental perspective. And what are your thoughts on evidence-based medicine and the difference between what we perceive it to be or are told it is and what it really is?
Yeah. So I'm showing my age and my process because I remember when this started to really come into the clinical medicine side of things, early 2000s. So, 20, 25 years ago. And there was a very good and healthy premise behind it. And it was to start getting clinicians to actually, follow the science, get yourselves up to date. If you're doing things that are out of date, because it's what you were taught 20 years ago and you haven't upgraded, that's not the best way to practice medicine. Mm-hmm. So that was sort of, its guiding premise of just trying to bring people up to date and keep them up to date. But then in doing that, there was then they sort of said there's levels of evidence. Mm-hmm. And that was just basically how strong a foundation are you building what you do upon, reflecting on what is actually then also feasible and possible to have in the first place. Mm-hmm. So, like you said, they have the top of the tree type things, which is randomized controlled trials, which then can be split to higher levels. Again, if you want to do a meta-analysis of all of those and start pooling those things and just try and climb up the ladder even higher again, in terms of trying to give yourself a stronger foundation that you're standing upon. But then they were like, well, what if we don't have that? What if we don't have randomized controlled trials? And then sort of go down a few notches. And you come down a few notches, you might go, well, we've got case series. So, we've got a case series where we did this in 100 people, and this is how it played out. And then we might just have case reports, things that are super rare. You're the fourth person in the world that's had this, and this is what we did for you. Well, that's really useful information to share with people that might happen to trip over the fifth person in the world that gets this. Because clearly there's no playbook. You're basically going back to first principles, and effectively in those scenarios, trial and error. And then you go down the list again where, they just talk about expert opinion. And that's the one where, well, I've been doing this the longest and I know, a lot about this, do as I say, do as I do sort of stuff. And again, that's good, but if you've been doing the same thing for a long time, you get really good at it. But if something better has come along and you don't, that's where the evidence-based medicine was trying to guide you to saying, hey, look, we're not trying to undermine the fact that you know stuff or the like. But at the end of the day, you got to try and keep up with the rest of us because we're moving past you here. So that was the premise behind it. Now, where it has been most beneficial is in the world of medication, because you can do a randomized controlled trial. You can take 10,000 people that have got high blood pressure and you can give them drug 1 and placebo 2. And you can do that in half and half, and you can look at things for a period of time and so forth. And that's often what is required to get medications over the line that you then intend to give to the masses. So that's why drug development takes so long, for example. But every now and then you got these really rare conditions where, and you've got limited medications and you just don't know if it's going to work or not. And that's where we start going off-label or get authority for special use. Over with you guys in the US now with your FDA, you have a fast-track approval. That's kind of like, especially with people like cancer, you say, look, we've run out of all the cancer drugs that are approved. We've got this one. At the end of the day, we're admitting it's experimental. We don't know it's long-term. We don't know if it's going to help or not. But look, you either just sort of, do you want to give it a go or do you want to just start palliative care? Or, at least give the opportunity to reflect on it, knowing that there is no evidence base for it that's to the standard that is a strong foundation. So when we work in clinical medicine, we really work across a blend of things in terms of what we do. Part of it is what we've taught, part of it is this is what we've always done, part of it, hey, here's something new, and so forth. Now, I live in a world of surgery. Now, people say, well, you can't do a randomized controlled trial of surgery where you do operation 1 and then sham surgery 2. Well, people have actually done that, and I have no idea how they got it through the ethics committees, where people have actually come into hospital, they've had an anesthetic, the surgeon has made a cut, opened things up, and like in ENT surgery, there's one with the ear where they drill part of the bone away from the ear. So, in half the people, they just made the cut and then just stitched it up. The other people, they actually opened it and drilled the bone out and then stitched them up to sort of see what it was. Now, you never get through that through ethics committees anymore. This is Wild West 60s and 70s stuff. Surgery, at least. So if you want to look at the evidence-based things for surgery, we don't have as strongest foundation as we do for medication. But that doesn't mean then that we stop everything we do because we don't have that tier of foundation to build upon. We just acknowledge, and what I see as time has gone by with this evidence-based medicine thing, and I think it's a really good sort of segue point for people, is to go and look at something that was written in the British Medical Journal. And when this was really taking off, it was ramping up, and I will call them the academics, the ones that were in academia more than clinical care, insisting on the ideals rather than understanding the realities. We're saying, look, if you don't have this, you can't do anything because it's not good enough. It's like, well, you're basically throwing the baby out with the bathwater there, and in terms of getting rid of a whole lot of good stuff that we've got, even though we don't have what you want or need to make you happy with it, we're still pretty content.
Yep.
And in the British Medical Journal, it was sort of a bit of a pushback, a bit of a counterpoint to this evidence-based medicine, and it was centered around the fact that there's no randomized controlled trial of jumping out of an aeroplane with or without a parachute. Mm-hmm. And within that narrative, they did explain the fact that people have actually jumped out of planes with a parachute that hasn't deployed. And there has been a cohort of people that have survived in doing so, which is pretty remarkable. They're pretty banged up, obviously. But, they survived. You say, well, I've got case reports where people could jump out of a plane without a parachute. Mm. So therefore, it is contentious that everyone that jumps out of a plane always needs a parachute. So what do you do? A randomized controlled trial? We're going to go half people jump, half people don't. Or can we just pause for a moment and go, well, look, common sense is allowed to prevail at times. Mm-hmm. And the other thing which I think was going to be very interesting in this space, just to round off my answer, is this whole thing of AI. Drug development has changed because of AI. Previously, you had to know the molecular structure of the target receptor, and then you had to go to a lab and try and work out the molecule had to look like to integrate with that receptor, and then you had to then try and guess things. Now, when you start developing drugs, and this goes back to a little bit of chemistry stuff, when you start putting molecules together, those chemicals then start to fold upon themselves. Mm-hmm. And the ability to work out folding of things for humans was that you could possibly, at a stretch, once you get to about 12 molecules, if you were lucky, you might be able to have some sense of what it would look like just applying an extensive amount of mathematics, chemical interactions. Now that AIs can do strings of protein folding. Mm-hmm. I think it was Google that basically cracked that one a little while back. So all of a sudden, you can model these far more complicated molecules, and you don't just do one of them, you can do thousands of them. Mm-hmm. And then you can go, that's the best fit. Mm. And then the AI can help you actually make it in the lab as well. So what we can potentially use this as a tool for in pharmacy development, we can also use in clinical medicine, because the AI hasn't got through the entire library of PubMed yet. But when I was doing my PhD, that was like PubMed, put in search terms, try and find these papers, mm-hmm. Draw.
Yep. And
find a good number of them, but I clearly wouldn't have found all of them.
Right.
The AI doesn't have to do what I had to do. It's basically already got an indexed library. And I think we will touch on this because I shared it with you just to show you what it can do. But, you can say, look, I want to do, something, and I want to know what could go right and what could go wrong based on all the published evidence that you can access. Mm-hmm. And it can actually do the number crunching for you. You can say, look, there's a risk of this for this, but there's a benefit of this for that, mm-hmm. And so forth. And we might come to that, Mike, at some stage, because I know I shared that little bit of play that I did with you. But
yes, we'll do the CBCT discussion. I'll definitely want to hear. I'll bring that back up. Yep.
Yeah. I'll sort of just round it off there. I think we're going to have a new tier of evidence-based medicine, which is going to be AI. Once we get the AI up to scratch, and look, people say that's going to take 10 years. I'll accept that. But from what it's done, from what I've seen in the past 2, where it's gone from nothing at all to I don't even do Google searches anymore kind of stuff. Mm-hmm. Sorry, Google, they ate your lunch. Yeah.
Yeah, I appreciate you explaining it in that context. It's great to get the medical perspective and the historical perspective. And to your point, Sackett with Rosenberg, Gray, Haynes, and Richardson published in British Medical Journal in the mid-90s about evidence-based medicine, what it is and what it isn't. And they specifically said, and I want to hear your thoughts on this, Bill, as it relates to the profession of orthodontics, dentistry in general. Mm-hmm. they said that, exactly to David's point, if no randomized control trial has been carried out for a particular patient's predicament, you must follow the trail to the next best external evidence and work from there. You don't say there's nothing to this. You don't say we don't look at this or do this. And they said without clinical expertise, practice risks becoming tyrannized by evidence, because they talked about the fact that even excellent external evidence may be inapplicable to or inappropriate for that individual patient. I feel like our profession of orthodontics, especially in academia, even so the AAO or the AGODO, they don't acknowledge the fact that evidence-based medicine is the overlap, if you look at three circles of clinical judgment and expertise, relevant scientific evidence, which David was talking about, and then the patient's values and preferences. Evidence-based medicine is the sweet spot in that Venn diagram where they overlap. Do you think, what percentage, sorry to put you on the spot for a number, but what percentage of orthos out there, especially in academia, do you think really know that? And do you think that's the message that we're conveying to young docs?
Yeah, you've got a great point. A couple of examples of things that are not really randomized controlled studies, but that are true. Number one, you would never do a study to determine if anesthesia has any effect upon the extraction of wisdom teeth. James Ma brought this up a number of years ago about evidence-based. It's just, again, it goes to common sense. Yeah, I mean, if anesthesia and all has nothing to do with the surgical techniques or anything like that they are still the same. But who's going to volunteer to get their wisdom teeth out and not be anesthetized? I mean, you're not going to happen. It's that same thing that David talked about. Who's going to jump out of an airplane at 10,000 feet? Now, they did do a study, David, on people jumping out of an airplane without parachutes, and 100% of them survived and none of them got hurt. The only thing at the bottom of the conclusion was they were 1 foot off the ground. Then they went in and said, okay, now let's try to get some volunteers. Let's go up. We're going to give half of y'all a parachute, half of y'all not. Well, guess what? It ain't going to happen. So, and another thing that's in the medical side is, what about the treatment of club feet? Are you going to do a randomized control sample on treatment with infants with club feet and say, all right, let's treat this group, let's treat that group, and see who walks and runs better? I mean, it's not going to happen. There's certain things that are just unethical. You cannot make a control sample by withholding treatment that may have some benefit. But in the drug, it's a little bit different. But, I mean, technically, to be able to do a study that just 100% proves that, narrow arches and all this stuff makes a difference, you'd have to take, number one, you'd have to take an enormous amount of children. You'd have to treat half of them and not treat the other, and see who develops comorbidities and things that are related to that. And you're just not going to do it. So there are certain things that are just, you've got evidence-based and you've got to be common sense about it, because the whole point of that was developed because there was a lot of anecdotal information that's out there, and you're trying to bring it to as much science as you can. But, experience-based medicine, expertise or whatever, I mean, that's the way the whole thing started to begin with. We do this treatment and it worked, and it keeps working and keeps working, and you go, okay, I'm going to keep doing that. You do a treatment that you say doesn't work in your hands, and you go, I'm not going to do that again. Okay. So, it's what works for one practitioner may not necessarily work for another practitioner. That's the get such variability. It's just like David is a surgeon. There are a lot of pediatric ENTs that wouldn't touch a young infant deviated septum or some of these other things. They're going to wait until they grow and then try to do it. Now, David, I think, would say he has his evidence and his experience that he can, because he does certain things a certain way. So just because you're trained in some kind of a, whether it be ENT or orthodontics or whatever, you can't assimilate all that information. That's why AI, I think, is going to be great. But here's the other negative part of it. Garbage in, garbage out. Where does the information come from? You've got all these articles that are written about a subject. You can find as many over here that support your topic and as many over here that doesn't. So when they blend all that stuff together, what you're trying to do is come up with something in the middle, that, okay, this seems to be the most reasonable approach to this type thing. And it's not just black and white. I mean, it's not just, hey, this treatment works 100% of the time and this treatment doesn't work 100% of the time. There's nothing out there that's like that. But that's what, if you only believe what's evidence-based, and here's another thing about statistics. Mark Twain said it very well. There are lies, there are damn lies, and then there's statistics. And if you're only going to believe what it's got to happen 95%, we put it at that 0.05 level. So in other words, we look at things and go, if it's not 95% successful, then we're not going to believe it. What if it happens 90% of the time? Okay, what if it happens 75% of the time? Those 75 or 90%, that's 100%. I mean, people say, well, if it's 50%, it's a flip of a coin. Let's say 50% of the children that walk in an orthodontic office, it's probably a little less than that, maybe at 30, but anyway, have some form of sleep disordered breathing. Does that mean we should ignore it because it's not 95%? Right. I mean, it's just, you really, when you start saying that you're only going to believe things that are, quote unquote, the evidence-based literature, or you're only going to believe things that are at the 95% level of confidence, you're looking down a straw. And that's all you're seeing. Everything else out here, medicine would never progress if you only look down that little straw at things. Yeah. So you got to use your judgment, and yes, you've got to be practical about it, common sense. I mean, but that's how medicine's evolved, trial and error. I mean, that's kind of, but not saying that that's what we need to do. That's where evidence-based medicine and dentistry has kind of tried to rein us in a little bit, which is probably okay. Yeah. But still, there are a lot of things out there. We could probably go to ChatGPT and say, what are some of the major medical breakthroughs that occurred that never had randomized controlled samples or whatever? There's probably just thousands or millions of them out there that they are what they are, but they don't lend themselves to such a rigorous statistical analysis or whatever.
Right. The premise of it, as David indicated as well, the premise of it is great and noble. And that is, instead of being the wild, wild west where it's like, we just try this, it's expert opinions, and I try this, you try that, which, yes, some of that will stick to the wall, but you could potentially do harm, and you're not necessarily basing it on sound science. The premise is good. A couple of the examples in the medical world, like insulin for diabetic ketoacidosis. There was no randomized control trial for that. Penicillin for bacterial endocarditis. There was no randomized control trial for that. They tried it. It worked really well. And they said, this is successful. And they used common sense and said, okay, let's go ahead and make this part of our normal protocol. And in 2016, John Ionizing, he was a friend of Sackett's, and it was a year after Sackett passed. And he wrote an article in the Journal of Clinical Epidemiology saying evidence-based medicine has been hijacked. A report to David Sackett. And what he's talking about is it's been hijacked by people with ulterior motives who, and a lot of he talks about is kind of big pharma, big medicine. They want you to believe a certain drug or is what you need to, or a certain protocol is what you need to follow. So they tell you this is evidence-based, and they run a study, like you said, from Mark Twain, lies, damn lies, and statistics. And they make that study they tailor it. And all of us who've been involved in research, which all three of us here have, as has many of our audience, you can adjust your variables accordingly to try to get certain outcomes to be a little more likely to show up than others. And so they then use that to say, well, now this is the evidence basis. Doing anything else is not performing the best treatment for your patient. And that is not the intent. It's like that pendulum swung too far the other way, right? We don't need the wild west where we're bloodletting and trying to think if we cut something off, does that, cut a hand off, does the patient get better? We also don't need it where if there's not this amazingly pure randomized controlled trial, that we don't use common sense and say, hey, wait, maybe if I go in and look at this kid a little younger than we're told, and start to look at their airway and their breathing and how their face is growing younger, all of which is based in science and evidence and data in the medical and dental literature and even orthodontic literature, maybe I could do something a little younger to help this child's health. Right? I mean, isn't that, and on that, one of those things is, take us to our next topic, CBCT and cone beam. And that is so heavily debated in the dental and orthodontic arena. So, David, you had referenced before something you put in the chat, GPT. And so I'll just preface that by saying a couple of things that people in my profession will say that are resistant to the concept of CBCT imaging. They used to say it was too high radiation. I know you're going to talk a little bit about that. Obviously, with these lower dose machines, really has become irrelevant. But even if it's not one of the low dose machines, you're going to talk about some of the data on that. The other thing that I hear is, well, it's not the gold standard for evaluating airway, and it's not endoscopy or using a scope. And I say, but that doesn't mean what we see is irrelevant or not a relevant finding that helps out with the screening process. So, what are some of your answers to, what are your thoughts on the naysayers who feel like there's really no need or benefit for 3D imaging in younger patients?
Yeah. For sure. So look, I see this as something that has benefits that you two can talk to better than I can from an orthodontic assessment point of view. And I'll just reflect on it from an ENT point of view. So the first comment in terms of from the ENT point of view, just to make sure that we're not trying to be divisive here, we're trying to bring everybody back to our conversation. I would agree that the endoscopy is the gold standard. Okay, I'm not going to argue that point because of course it is. Looking at the real person in real time with all the gear and kit that we have got is absolutely the gold standard. I'm not disputing that at all. So I'm not suggesting that the CBCT is somehow trying to replace that at all, because that is where the argument is, well, because it's not this, you therefore can't do that. That's not the case at all. No one is suggesting that CBCT is a gold standard. Right. So is it then one notch down from that, where you can say, can you consider it screening? Can you consider it opportunistic? So if within the orthodontic realm, which I know you'll speak to, as a clinician, you feel, just like Bill said about a whole lot of things before, if you feel in your hands, in your skills and your knowledge and everything that you do and the way that you do it, which is founded upon the best evidence and experience combined, because it is a blend, you feel that a CBCT, for an orthodontic point of view, gives you much better information, much greater ability to treatment plan than the alternate imaging, then you are demonstrating a benefit. Now, we're going to counter this with the risks in a sec, but you are demonstrating a benefit. As orthodontists, you are able to give a better treatment plan, outcome, etc., for the patients that you care for. So that's, we'll talk about risks and benefits. So there's your orthodontic benefit. Let's jump over to my side of the fence now. And Bill, I think you're right. A middle of the road number is about 30% of children rocking up to an orthodontic clinic have airway problems. Now, I can show you papers where it's 60%. I can show you papers where it's 80%. All right. Let's just take a middle of the road approach. Let's take 30%. All right. So to me, that would be a low end number. Now, we know in the general population, depending on how you define sleep disordered breathing, some people are still locked in the sleep apnea segment of that spectrum, thinking that's the be all and end all, which it's not.
We'll come to that. I'll be asking some questions on that too.
Which it's not. That's the worst of the worst. That's kind of like the stage we don't want them to get to. We like to find them before we get to that stage, because the lesser the disease, the better we can fix. And I recall way back when we did our talk, Mike, we were talking about stages of cancer way back in the day. It's like, well, it's only a little tiny cancer. Those sorts of cancers won't kill you, but if it gets bigger, it will. So we'll just see what it does, and if it does get bigger, then all right, we'll fix it for you. Right. So anyway, we'll move that past that nonsense. So it's the same with airway. We don't go, it's just a bit of an airway problem at the moment. Well, let's move on. So we have 30%. All right. So now the background population rate of sleep disordered breathing is nudging up there between 15 to 20%. So there, regardless of where we draw those lines in the sand, there is an overrepresentation of children presenting to an orthodontist with airway problems relative to the otherwise general, in inverted commas, normal population. So when we look at screening, we don't screen entire populations in general, because economically, that's a lot of money you spend for something that you may not pick up unless it's a really common problem. So, for example, for women breast cancer screening, we will offer population-based screening after a certain age, because there's a numbers game where it's a very common condition. Finding it early is obviously better than finding it late. So we will do that, but it's very expensive. We have, at least here in Australia, we have what's called universal newborn hearing screening. That is where we will check every single child that is born within the first week to see if they have a congenital significant hearing loss. We'll miss the minor ones, but we're looking for the big serious ones. And the reason we do that is we know that finding those children and getting them with a cochlear implant early changes the trajectory of their life in such a way that the screening is so cheap, and then the outcomes are so beneficial from a cost-benefit analysis, which is part of what comes into healthcare. It's worthwhile. So let's now look from your point of view. So you have a cohort of children that have an increased risk of having airway problems, probably by a factor of 2, as a minimum, a factor of 2. Okay. And you're not doing the CBCT to look for airway problems. It just so happens that because we're in the same territory, that in the process of acquiring the data that you're acquiring for your purposes, it happens to trip over that we're actually getting these extra, side benefits of it all, in terms of what's useful to then, if you start looking at this from a whole patient point of view, and part of your clinical approach as a dentist or orthodontist is to ask about these airway problems and then synthesize that with the incidental, opportunistic CBCT findings, and in doing so, identify an airway problem that is otherwise being missed. And again, you are not diagnosing an airway problem. You are identifying a collection of symptoms, signs, and supplementing that with investigation findings that leads you to advise the parents as part of your comprehensive, holistic, patient-centered care to say, hey, look, I'm really glad you're here, because clearly, you can see the orthodontic problems, and I obviously am the orthodontist, so 2 and 2 is 4 on that one. But I'm just going to sidetrack you a little bit, because in the process of taking these images and just clarifying what I'm doing and treatment planning out what you came here for, I think I found another problem. And as the process of doing that, I think it would probably worth you seeing an ENT to get some clarity about this. I'm not suggesting that you've got this problem. I'm not saying it needs fixing, but I am concerned to the point about the well-being of your child that I don't want to be the person that was next in the line of people healthcare-wise that miss this. Because I know from my experience, from my training, from my teaching, from my reading, that children that have these sort of symptoms that you told me about your child and matches up with these sorts of things that we've found in the scan, there's actually a really high chance that the ENT is actually going to take this on board and give you a treatment plan that involves managing your child's breathing and sleep problem as well. All right. So that's an extra layer of benefit. It wasn't the intention of the scan. Is the gold standard still the same? Yeah, we haven't changed the gold standard. Have we substituted the gold standard? No, we haven't substituted the gold standard. Have we found a group of kids that are going through healthcare systems that have otherwise been missed, and in doing so, put them on a pathway that can lead to much greater health outcomes for the long term? And the short answer is yes. And what did it cost us? Nothing, other than the radiation dose. That's the cost to the patient. So this is where you go, all right, again, from a CBCT point of view now, we are dealing in the era of low dose radiation scans. So it's like Bill said before, we can pull out research and publications, but it's dumb to pull out stuff from the 90s and the early 2000s because we're not talking about the same machines anymore. Let's talk about the machines that we're using now, and let's then use some of this technology. Let's use this AI, because this has all been mathed out by clever people. We are worried about radiation exposure, and not just from medical scans, but go way back to the day to Marie Curie. What happened to her? They were literally just playing with the stuff with their hands. What happened? Well, down the track, she got cancer, but it happened a long time down the track. And we know the history of the watch dials, where they were painting the radio luminescent watch dials, and eventually, because the people were licking as they went, they eventually started getting cancers. But eventually, so it's not like exposure day one equals badness day two. It takes a long time, and it doesn't happen in everybody. So people have mapped out what we would call the risk, the relative risk. So what is your background risk, and then what can you do in your lifetime that can escalate your risk? And we can talk about cigarettes, we can talk about alcohol, we can talk about diet, and we can talk about medical radiation exposure. And people have done the math, so this is where the AI can do the heavy lifting for me, because I don't want to sit down and work out the math. I got the AI to do it. And Mike, you might be able to sort of splice, what I shared with you.
Yeah, I'll overlay it for people who want to watch the video feed at this point. I can put in the slides that you sent. Yep.
Yeah. And I think this is one of those ones where I know most people like me with podcasts were actually, just doing it in the car, but this is one of those ones where you might just want to bookmark a few of these things, because when we put these images up and you start looking at it, you start to see a different reality to what you might have thought. So when we look at the relative risk of having a CBCT in terms of cancers, does it increase the risk of cancer? The short answer is yes, it does. Now, already that goes, oh my gosh, that's red flags, that's badness, that's, oh my gosh, oh my gosh, oh my gosh. You go, all right, yes, it does. By how much? And the answer is very, very small. All right. But here we go. We have a risk. So if someone is black and white and only gives you a yes, no answer, does having a CBCT increase your risk of having cancer in your lifetime? The answer is yes. Now, if you stop the conversation point there, then you're missing the boat, because you go, well, how big is that risk? And it is tiny. It is so tiny that what you need to then counterplay that to is, how does that compare to other things that increase your risk of radiation exposure? And the typical example is long-haul international flights. So every time I fly to the US and back is equivalent to me having a CBCT, pretty much. Okay, I've increased my chance of having cancer by flying internationally. Now, do people all of a sudden with that statistic stop flying internationally? No.
Of course not.
Of course not. All right. Why? Because there's a benefit. There's a benefit. I'm going on a holiday. I'm going to go see my friends. I'm going to go have experiences and so forth. There's a benefit. And the risk is tiny. It's so small. So that's that. So then we go, all right, if we're going to have this risk, we've got to have some health benefits. And the health benefits are not what I talked about in terms of the orthodontic ones. The health benefits is, what is the long-term health benefit to a child with undiagnosed sleep disordered breathing that is found and fixed as a consequence, purely and simply, of this CBCT being done. Okay, and if there's a demonstrated health benefit, then we can quantify. Then we can start to see how this plays out. And this is where, again, I got it to do the math and say, look, if we find a child that has sleep disordered breathing that no one has found, and we find it, and we run a 30% number of children that we find, what are the long-term health out benefits in terms of things like the chances of having high blood pressure, having been treated versus not, diabetes, stroke, behavior problems, learning problems, all these sorts of things. So what I did is I said, look, I'm going to give you 100,000 7-year-old children. Pretty, huge numbers. You'd never see 100,000 children that you could sit down and compile the data on. So we'd be running on AI-generated compilations and simulations here. And I chose 100,000 because it's there. And I said, look, focus on cancer risk, airway obstruction detection, and long-term outcomes. Okay? So this is a simulation. And so if we go to the next slide there. So it worked out, typical dosages range from this to this, and your background dosage. And the estimated cancer risk per CBCT is 1 in 100,000. So if we had 100,000 children, okay, that go through a CBCT machine, and I said, does it increase the risk of cancer? The answer is yes. By how many? One person. One person. So relative risk-wise, as it says, it's tiny. It's so small there. So then let's offset that risk. So we jumped over to the next slide. All right. And we said, look, let's run on a 30%. And think about this, like if it's 60%, all these numbers just doubled. Right. Let's run on 30%. All right. And things that, you will commonly find. You see the adenoids are big, that, there's obviously with the jaws and stuff. So we said, right, for 30% of kids, that's easy. That's 30,000 children all of a sudden we're about to find in that cohort. Okay. And if we don't treat them, okay, 3,000 to 4,500 of them are going to end up with high blood pressure. Because we know that sleep disordered breathing causes a whole lot of permutations in terms of the cardiovascular system, and those things in time lead to what we call in medicine primary hypertension. So primary hypertension means you've got high blood pressure and we don't know why. Now, it comes from this. There's a good cohort where it comes from this. So these children would otherwise end up with high blood pressure, which increases their risks of having a heart attack and stroke. Okay, and of the big killers, heart attacks is still top of the list. Cancer's not far behind, but cancers, so forth, that we bumped up by 1 in 100,000 versus 3,000 that we saved from high blood pressure. Okay. And then we look at brain function and development in terms of how this impairs their brains. Okay. 7,500 of these kids, which was 25%, which is right. When we look at these scans, when we look at the data, when we put these kids through MRIs and look at their brain function and development, that's pretty much on the money. 25% of these kids or more show signs of, call it what it is, brain damage. Okay. So we have just saved 7,500 children from neurological impact. And we know the data, we know the research. I chose the age of 7. Why? Because that was the research on the Karen Bonnock way back in 2012. Where they looked at kids up to the age of 7 with untreated sleep disordered breathing and then looked at their outcomes. And what were their outcomes? Poor behavior, poor learning, etc. So these are real numbers, okay? And then we look at things where the heart is actually changing. The heart is under so much stress and strain that it's starting to have to remodel from what it's supposed to do to make the adjustments. Okay, and that's about 1% of the time. So that's still 1,000 kids with heart disease that we save from heart disease. Okay, and having sleep disordered breathing in its own right is a risk factor for cancer. Okay, how many kids did we give cancer to? 1. How many did we save? 30 to 90. Okay. That's the simulation. That's the numbers. So if people want to say radiation causes cancer, I'll agree with them. But you know what? Radiation used in a certain way for a certain thing that shows us certain things that are relevant to sleep-disordered breathing will save 30 to 90 people at the same time from cancer. So if you have a risk to benefit analysis that you needed to basically weigh up, you say, look, for every one that we give cancer to, it's 30 that we save. That's a no-brainer. Absolute no-brainer. You know, forget about all the other stuff I just mentioned about brain and cardiac. If you want to focus just on cancer, that's the numbers right there. Okay? That's the numbers. So in terms of a risk versus benefit analysis, you need to talk about the whole picture, not what you want to cherry pick. Because again, this is kind of, like I said, this is probably the new frontier in evidence-based medicine. There's no way that I could have sat down and trawled through those papers and worked out, the cancer risk for things. And the cancers that were typically, related to that we know of, one of them I mentioned is breast cancer. Colon cancer is on the list. My neck of the woods, melanoma. Australia is number one in the world. California, which thinks it's its own country at times, is number 2 in the world. So from that point of view, melanoma is a big deal down here in terms of skin cancers. And having sleep apnea increases your risk of having worse outcomes. So from my point of view, if we can find things and fix them early from an ENT point of view and airway, and it just so happened to have come by the virtue of dentists, orthodontists having done a CBCT for other reasons. This is the whole circle back.
Right.
You're not doing this to check their airway.
Right.
You're doing this for orthodontic reasons. It just so happens it has a side benefit.
Yep.
It'd be like me doing sinus scans, and every now and then we'll find a brain tumor. We weren't looking for a brain tumor, but every now and then we'll find a brain tumor. Why? Because we're just in overlapping territory. And in the process of doing the scans, we get some brain images and, oh, hey, there's a cancer there in your brain. And what do we do about that? Do we, say to the patient, oh, look, we should never have done this scan because, we were never looking for brain cancer?
Right.
That's killed me. It just so happens that it just happens to be a very positive side effect.
Right.
If you want to call it that, of doing this stuff, is every now and then in clinical medicine, we'll find stuff we were never looking for. The difference here is that you're not looking for airway problem as the reason you're doing the scan, but you are going to find a lot of them. Like I might find a brain cancer once every 5-10 years. You're going to find airway problems 1 out of every 3.
Yeah.
Maybe even 1 out of every 3.
Yeah.
All right.
Yeah, I was shocked when I started doing them and I started looking at these images. I couldn't believe how common it was. I'm like, my gosh.
This is why I used 30% because that's AI said 20 to 40%. That was the numbers it landed on. I didn't prompt it or anything, based on whatever the reported rate of airway problems, and it said 20 to 40%. So I just split in the middle and said 30. Now, again, I think it's actually 60. All right. I think, and maybe I'm just got a lot of experience working with dentists and orthodontists that have been on the CBCT road for a long, long time. And maybe I'm biased in that respect, but but I've got the research findings that suggest that it's 60 as well. So if, for example, I'm right and it is 60, well, those numbers that we just had of benefit, they just doubled. Instead of being 3,000 blood pressure, it was 6,000 blood pressure. Instead of it being 30 to 90 cancers that we found, it becomes 60 to 180 cancers that never showed up because we didn't have the airway problems. The neurodevelopment stuff, instead of it being 7,500 kids, it's 25,000 kids. Okay? If you presented this to the parents and said, hey, look, I'm going to do a scan, and as part of this is all for orthodontic reasons, but every now and then, and actually every now and then is 1 in 3, we find additional problems that are ENT airway related. And by doing so, we're going to reduce the chance overall of your child having cancer from, the background population rate 30 times more so than the chance of me giving them cancer from this radiation dose. Do you want to have a 30 times risk reduction in cancer by having the scan relative to the risk of increase? So I've got a 1 in 30, you've got a 1 in 100,000 that they'll get cancer, and we've got a 30 in 100,000 that you can actually change their life and they won't get cancer. That's the math. Forget about the emotion. Forget about anything else. This is where I think, like I said before, I think this is where these AI things, and especially as they get better, and the numbers I given will get more refined and so forth over time. This is sort of mud map stuff at the moment. I'm not going to say that this is scientific proof as such, but it's using the science to generate these numbers and give us guiding principles. So we can't do this study, but can we simulate this? Can we amalgamate what we know? And in doing so, what does it tell us? And if it tells us this, we've got to listen to it. And if you want to say, well, look, I think that whole thing about cancer is rubbish, fine, ignore it. You can't ignore the blood pressure. You can't ignore the brain stuff. You can't. Those numbers, we're levels of evidence, we are far more rock solid than those. Yeah. Far more rock solid. Yeah. We got plenty of stuff there. So I think that's my sort of take on CBCTs. Do I personally need a CBCT? No. Why? Because I got the scope.
Right.
Okay. All right. I've got the scope. Right. So it's not like I need the CBCT, but if you guys as dentists, orthodontists, as part of orthodontic planning, you need imaging. Okay. Now, whether you want 2D fuzzy cloud stuff because that's what you do, and in your hands that's still how you do it the best, I respect that. But if you've found a better way in your hands that you can compare to over time, well, that's what you're going to do. And then what are you going to do? You're going to teach the person under you to say, hey, look, I've lived in two worlds. I've lived in this 2D world. I've lived in this 3D world. I have found personally that the 3D world is so much better. I can see so much more. I can treatment plan better than I ever used to. And I'm looking at my results in my hands. I'm getting better results. Now, I haven't done anything different in terms of, being an orthodontist in terms of the wires that I use, the brackets that I use and everything. But the way that I use them has changed. And the outcomes that I get are better and so forth. And it's not like you're insisting that people have to change because you did, but people can't then also go the other way and say, that such change needs to be resisted because it's not what they want to do either. Right. If you're getting better results and better outcomes, and so forth, and this is again, you can be in that sweet spot where you've been from one school and you've then been to the other, and for yourself it makes a difference. That's where it all starts to play out in terms of where you're saying that on the levels of evidence, it's kind of like, it's personal opinion founded on some really good rock solid realities. And it's what we do in surgery. We do the same thing. We go, hey, look, I've got this tool. I've always done this operation this way, but now there's this new tool. All right, I'll try it. And you go, oh, wow, this is actually a much better tool for me to do the same thing. So I've lost track of how many ways I've learned to take tonsils out. If I was to do a head count of the number of ways I have learned to take tonsils out and so forth, and then I changed again about 3 or 4 years ago. Okay? I've been taking tonsils out since 2000 and something. All right. So, and every time I evolve and progress. And, should I be doing it the old school way just because that's what I was founded upon? Or have I found better ways to do the same thing? And the short answer is, I have. Now, does that mean that everybody has to do it because it worked for me? No. But why would I want to go back to something that's old and clunky just because that's the way that it's supposed to be done, because that's the way it's always been done?
And that's actually the thing, I think, right there, that's what you just hit on, that I want to hear Bill's take on that, because I feel, first of all, I should stop saying thank you for that explanation. That was absolutely outstanding. And I hope that everybody in the dental and orthodontic arena passes that along. Even if you just want to clip that part, pass it along to your colleagues who question this and doubt this and don't understand the data, because it is just so nice to hear it laid out so clearly and succinctly and directly as to why these have this benefit, as you explained, side benefit, as you explained, to looking in greater detail at the patient. What you just finished with there, which I want to hear Bill's take on, because I think there's so much more to it than that. And I feel, maybe I'm wrong, but I feel like even hearing what you just said, David, a lot of our orthodontic colleagues, Bill's starting to smile, will still resist it. you just said it perfectly, right? Why would you want to do the same thing? Why would you not want to innovate and evolve and grow? Yet, I know orthodontic practices that bought an office where there was a CBCT, and because they had multiple locations and they didn't have everyone trained on the CBCT, they traded down the CBCT for a 2D machine because they wanted their 2D back because their other locations are in 2D and they couldn't afford or didn't want to invest in putting new CBCTs in 4 offices or 5 offices. So I feel like our orthodontic colleagues were using the radiation as this sort of false front to say, oh, it's radiation. Well, now with evidence like you just gave, it's hard to make that argument. So I feel like now they're saying, there was this thing online recently, one of our orthodontic study groups, and they were saying basically it's too much information. We don't need that much information. I'm like, really? Like, said no one ever that we don't want more information on this stuff. So Bill, why do you think, because you have a huge history in 3D imaging, you're an innovator in this arena. You were, as you said on my show when you were on the first time, you were one of the earliest adopters of this technology. You've lived it. You've developed protocols for it. You were making things 3D before there was even 3D. Why are so many of our orthodontic colleagues, and even non-orthodontic colleagues, just general dental or pediatric dental colleagues, so resistant to this still?
Yeah, I think, like you said, I think the initial reaction is, the radiation dose is so much higher. David Hatcher and I did a study back, David Hatcher with beam readers. Many people know who he is, oral authority, oral maxillofacial radiologist, and his group, Danny Tamimian and a number of others are part of that group. But anyway, David and I, years ago, back in the 90s, I got to know David. And I did a little study. Actually, we got some funding for an NIH grant back in the 90s to compare 2D cephalometrics, 2D information versus 3D information. The simple answer is, which represents the anatomical truth. We wrote an article about that, the anatomic truth. And, 2D gives you a certain amount of information. It's static. It's one view. It's usually a lateral ceph. The original cephalometer, which was developed back in 1936 by Broadbent and actually Horfrath over in Germany, they kind of did it about the same time. But anyway, both of them used a frontal and a lateral ceph. And there was a way to correlated those things together. They had acetate overlays to kind of take out some of the magnification factors of these things. But it was they knew at the time that's the best they had, to look at 2 different views, and you're getting some mentally making some 3-dimensional information.
Because it also evolved from craniometrics, which was 3D analysis in the anthropological side of things. So they knew looking at 3D was right. They were just trying to get a radiographic representation of this. I've said that to many people. Like, we started in 3D, but what have you read on the reason why? Because I can tell you what I read on why it didn't take.
Well, one of the things, the frontal ceph kind of got put off to the side because they felt like everybody's symmetrical. So the only reason to take a frontal ceph was for symmetry, looking at symmetry of the mandible and that kind of thing. And they kind of figured, most people were symmetrical, so we're just going to go with the lateral ceph. And so that's kind of how it evolved. Now, Ricketts.
And the other part, sorry to interrupt on that I had read an article where they attribute also market forces, that the cost of 2 machines and the space layout in your operatory for those 2 machines, because remember, you can't move the patient. So you need this lat and the PA simultaneously taking these images. And people didn't want to spend the money on these machines. They didn't have the physical layout. So they just, with what you said, with the fact that, and the reason that lat-ceph won over is based on people were like, we're not seeing as much in the PA, was their opinion at that time. They're like, lateral ceph it is. And now we literally, it's our quote unquote gold standard, which is comical.
Yeah. And it really, like I said, David Hatcher and I wrote an article back where we actually took 2D Now, this was before cone beam CT, but we had a calibration device that we would use we did it on skulls to start with, and we put the calibration target, and then we did a lateral frontal ceph, so to speak. This was but like you said, the cephalometer nowadays, you have to rotate. You take the lateral and then you rotate the head, you rotate the whole patient, and then you take another one, so you're not taking them simultaneously. But we had a calibration target that we had created very accurately, so that when we did do that, we could determine orientation. So we took the old acetate overlay concept of these epipolar lines, and then what we did is we measured the normal angular and linear measurements on a lateral ceph, and then we were able to make, because of the calibration target, we were able to take those landmarks, and instead of the projective, the magnification factor, we were able to take the magnification factors out of there. In other words, we're creating an orthographic ceph instead of a perspective projection ceph. And what happened, the numbers are all over the place on 2D, positive and negative. I mean, way off. 15 centimeters of, huge deviations of these numbers. They were all over the place. We had the target because we had taken those skulls and then taken like a 3D pointer and be able to, come up with the accurate information. That was the center line. And so the 2D was all over the place. When we did the calibration, it tightened it up. It didn't quite it was weird. We had a left bias. We had for some reason it was a negative bias, but all the numbers came a lot closer together just from this simple little calibration device. Now, we didn't really get much more into it to try to figure out where that, if we could have figured out that bias, we would have just taken a frontal lateral ceph and creating these landmarks orthographically, we would tighten up that, quote, the anatomic projection of that. But so then that's when, cone beam CT came on the scene, and David Hatcher was really one of the first the first in the United States. The first one in the United States was at Loma Linda, Joe Caruso, but David Hatcher got his the next day and he said he's the first one to use cone beam. This was the new TOM, which was created in Italy, Yvonne Deuce on the lay down type. So when I started looking at this, because of some of the stuff that we did early about, really the fallacy behind what a 2D lateral ceph shows. Everybody looks at it and goes, well, you can see the airway in a lateral ceph. And I go, that's the pharyngeal area. That's the biggest wine bottle part. The little narrow top up here by the nose is what's really important. This is what David works on. It's the nose, stupid. It's the nasomaxillary complex. And Christian Guilleminault said it himself. I've got the video. If you don't fix the nose, if you don't get the child nasal breathing, especially during at nighttime, you have not fixed that child problem. And Dr. Guilleminault was one of the first in the world to say prevention, prevention, prevention. Get in there early. Audrey Yoon is doing a lot of this. She worked directly under him. So this whole thing's kind of started. Even Edward H. Angle, our father of orthodontics, back in the late 1800s, 1900s, was talking about airway and mouth breathing and how that affected the craniofacial growth. And so one of the things that I show in my slide presentation is a child with club feet. And I try to relate it to that. They go, look, when is a child with club feet, when are they treated? If you ask Stanford Ortho, I've called them, I've called the Ponseti Institute and others, and the answer is as soon as you see it. they've got casts on those legs probably the day they're born, at least within the first week or so, or at least the first month. They don't go much past that. Why? Because the bones are moldable. I mean, the head that's got all the fontanelles, and they've gone through a lot of trauma, but they're going to go in and mold the feet. And if they take the feet and they overcorrect them, because we know we have to stretch the muscles and the ligaments, and then we have to come back, and then they get them close. So by the time they're walking, then they may put them in corrective shoes to fine tune, braces on the teeth. Really, in my mind, braces ought to be used, or Invisalign. You ought to be able to treat all your cases simply if you go in there as early as you can. Now, it's about 4, 5, 6 maybe of when I can do it. There are other people like Kevin Boyd and some other people that treat them the day they're born almost. But, at least at 5 years of age, and one of the things that I think we miss, pediatric dentists see it better than we do because we're not going to see them that young, is all the primary teeth where they're all nicely lined up like little pegs and there's no spaces. We've been trained that the permanent teeth, they should all be lined up and look nice and look aesthetic. We translate that to the primary dentition. Parents will come in and say, my child's primary teeth, baby teeth, were so nice. They fit so well. I had no crowding. Guess what? They don't have enough room. You take a cone beam, and again, David's correct, because nowadays you can take a smaller field cone beam that goes from about nasion down to here on a child at about 15 or 18 microsieverts. Well, guess what the lateral ceph in a pan is?
Double.
30. Double. It's 30. So, and that's the information you get. I did the calculations. If you take at 1 degree increments in all 3 planes of space is 46 million something images. So essentially that cone beam is exponential amount of imaging, because you take a cone beam, you can look at I want to see the TM joints. I want to look at the nasal cavity. I want to look at the septum. I want to look at the turbinates. I want to see if the adenoids and tonsils are back there.
I agree. Why don't our colleagues want to? I literally, do you think it's fear of change? Do you think it's cost? What? Because it doesn't make sense. There's no logic to not wanting to see more about the patient.
Well, they've not been trained.
Right, fair, right. People don't realize that. I have a lot of lay people who listen to the show as well, and they might be hearing this and like, well, if you're learning this in school, no, we're not. I actually have had issues with certain residency programs because they won't let the residents take CBCT images for looking at anything but say
we are starting. We at UAB, and I'll have to admit, we're starting to do that, but it's the tradition has just been take a lateral and a lateral ceph and a pan, and whether you take physical study models or take digital study models, and that's your diagnostic criteria. But the thing is, you're missing one, and if nothing else, you're missing one entirely part of the dimension, and that's the transverse.
Yes. With no coronal view,
You're not looking at the nasal cavity. So you haven't been trained to look at that. You've been trained to look at just the lateral in front and make a decision on sagittal, because class 2, class 3, if they're class 1, we consider that, a normal growth pattern. And especially if they're class 1 with no crossbite, orthodontists are going to say,
looking good.
It's okay. They don't look at the transverse to see that, there's a skeletal narrowness, and then the teeth are dumped in, but they're dumped in the same amount. So there's no crossbite. Sean Carlson talks about this, and it's a lot of his is they did a study, and I can't remember the name of it, but it was done in the AJO about looking at the skeletal relationship, not just the teeth, but a lot of times these class 1 patients that are dumped in, skeletally, they're just as narrow as somebody that has a bilateral crossbite.
Completely. McNamara in 2000 in AJODO, his article, Maxillary Transverse Deficiency, he called it the most pervasive skeletal problem in the craniofacial region.
Absolutely. That's Jim McNamara.
That's McNamara and AJODO. I mean, yet our colleagues in most orthodontic residencies today, they still tell you if there's no posterior crossbite, it is malpractice. I'm not using that word casually. They tell residents it is malpractice and not in line with ABO recommendations, which that's a whole nother discussion for another day, to expand a patient in the absence of a posterior crossbite. Yet we have in our literature plenty of knowledge and evidence that this is not a patient that has a normal shape, size maxilla. And to your point, if that same patient did present with the same maxilla and a bilateral posterior crossbite, meaning the lower teeth are not caved in, right? They are upright over the bone as they should be. We expand that patient all day and twice on Sunday. I mean, it is not even a debate in our profession. And I say to people all the time, then why wouldn't you, with the patient that doesn't have the crossbite, expand the maxilla and upright the mandibular teeth?
Right? And that's where the problem comes in. We've been trained in orthodontics that the mandible's immutable and you can't expand. You don't have a suture. Okay, great. You don't have a suture. But that doesn't mean those lower teeth can't. They're leaning in lingually. They're collapsed lingually. They just so happen to collapse lingually, and the uppers have collapsed lingually, but there's no crossbite. But they're still narrow. Now, we're so focused on the teeth. And that's where cone beam comes in so great. If you take a cone beam, forget the teeth a minute. You need to don't look at the teeth. Look at the skeleton. And if you look at the skeleton and measure a 28 millimeter skeletal width, okay, maybe the teeth correlate to that or not, but it doesn't matter. It's the skeleton, because the maxilla is not a separate bone. It's only a separate bone when the oral surgeon cuts it away from the nasal bone. The nasomaxillary complex is one thing, and that's where orthodontists and ENT physicians, thank goodness, at UAB, we have made that connection. So we're going to try to get more. I think that's a critical part of education is orthodontics and ENT. Otolaryngology need to be tied at the hip or tied at the cheek or tied at the face or something, because we're dealing in the same area. It's just David's on the first floor and I'm on the second floor, but it's the same house. And if you've got a narrow maxilla, you've got a narrow nose. It's physics. It's just physics 101.
That's what I was going to bring into the chat is obviously, again, this is where you can get tunnel vision, because when the maxilla, that upper jaw is narrow, so it's transverse, so its side to side dimensions are compromised. The nose, that's the foundation for the nose. So if you just draw a triangle, an equilateral triangle, all three sides are equal. And then at the base of that triangle, you push those 2 points in towards each other in an equal way. You're narrowing the base, you're making that triangle smaller. That's something that people can probably visualize. Well, that is exactly what happens inside the nose. So I will see kids where they can't breathe, and so forth, obviously. And the things I'll see the big adenoids, I'll see the swollen turbinates. But the other thing I'll see at times is I'll see kids where it's their nasal passages. Their nasal passages are so narrow, that I might need to take out normal turbinates to some degree, just to give them some breathing space, solely to buy time for then expansion to play out, to widen the jaw, widen the base of the nose, and then reduce the restrictions that having a narrow jaw is causing upon the nose itself. So this, again, is where you get that tunnel vision, because if you're just looking at teeth and go, well, these teeth are lining up, they're not in crossbite, therefore everything is okay, that's a very, very simplistic approach to a patient. And it's too simplistic. Like you said, Mike, we've got the science, we've got the research. We're not creating problems that don't exist and therefore trying to justify solutions that don't have a cause. These are real things and real dynamics and real problems. And this is, what I say is, to parents, I say, look, as an ENT, I don't care about teeth. I don't care. Mm-hmm. I don't care if your child has crooked teeth. I'm sorry to break your hearts there, guys, but I don't care. What I do care about is the jaw's no good. And you've got one stage of life to get this jaw right, and that's now. Mm-hmm. All right? They can get the teeth fixed later on. The teeth, they can do amazing things with teeth and give you whatever cosmetic result you want because that's the mindset. But you get one chance to get the jaw right, and that's now. Mm-hmm. And if you don't get that right, it doesn't matter if you have the best teeth in the world, you're going to have health problems above and beyond that would, like we looked at those numbers, again, treating versus not treating for long-term health outcomes. Mm-hmm. So from that point of view, the benefit is there. And the timing is so important. It's so important to get into these things early and look at it from a patient perspective, not a tooth perspective. Mm-hmm.
And that is that point I really want to drive home, because all of our literature, the majority of, I shouldn't say all of it, the preponderance of literature that we learn as residents in the orthodontic specialty programs is talking about the fact that phase 1, phase 2, really no difference in the end. You can still get the teeth straight. I mean, you look at Gianelli and Tunkay and Schiffman and Little, Rydell and Stein in the early 90s and O'Brien, and you look at a lot of these studies from 1990 to the early 2000s, and not even studies, some of them were just opinion articles. And they talk about that you can get the same out that, now forget about the fact that their means of doing phase 1 were outcome standardized and there was all sorts of design problems. You still can do it without extracting teeth and et cetera, et cetera. So to your point, to both of your point, the problem is we are so hyper-focused on teeth that when I brought this up recently in the doc community on Facebook, someone said to me, an orthodontist said, well, where's any evidence that we can make any difference in the way the face grows with what we do? And what I said is, that's part of the problem, is we are thinking about it that we have to do something orthodontically to this young face to change the way the face grows. But as is well evidenced in the medical literature, and I gave a bunch of articles back to this individual, I'm not being critical. It's actually, I said it's a fair question because we don't learn this. The Gimeno and Wang article in 2018 Sleep Medicine Reviews, he talks about the fact that it's from oral facial dysfunction to dysmorphism and the onset of pediatric OSA. And we'll come to that in a second. But while on the mouth breathing and the way we grow, I said back, we need to think about the fact that maybe we are just detecting these problems in aberrant growth, because we are certainly the experts in that. And maybe we aren't doing anything at that time orthodontically. Maybe we are, but we start with noticing maybe there's a tongue tie and maybe they need a release or oral myofunctional therapy or both. Maybe they need to see the allergist. Maybe they need to see the ENT. And once we get them nasal breathing, they can start to normalize the craniofacial growth and development and not have all those behavioral and psychosocial implications that you had talked about, David. But we can't, it's outside of our reality, because it's such a fundamental paradigm shift to tell orthodontists we are orthodontists. It's not about the teeth. And I think we need to change our whole profession of our whole specialty, I should say, to be orthodontists. And I just had a great talk with Jack Fisher about this, and denofacial or craniofacial orthopedists, where we detect these things, work with our ENT, allergy, OMT colleagues, and then if that's not working or they need our help, yes, we can go in young and help expand and grow these patients, as Bill was alluding to. But it's not about straightening baby teeth. The lad said this one story, and then I want to hear, I'll keep it with David for a second on hearing the implications of mouth breathing, because that's a whole other thing I want to touch on. But I've had older orthodontists, I've been told that they say things like it is malpractice to put braces on baby teeth or to be moving these teeth so young, that an ABO orthodontist or certified orthodontist should never be treating a patient this young. This is because they're so focused on the teeth. They are literally myopic, and they can't understand that there's a patient attached to these teeth. So with that, David, please talk a little bit more from your area of expertise. the medical side of things, why is mouth breathing in younger children an issue?
Absolutely, yeah. The thing about mouth breathing, again, and this would be my dream slide, Mike. All right, I'll never get this invitation in a million years in Australia, and I reckon I can double that in the US, where I will get to present to the Australian Orthodontic Society. All right, and my slide is how does mouth breathing affect the teeth, or affect the jaws? And my next slide is it doesn't matter. And there's a reason it doesn't matter, is because I can give you a list of health implications of mouth breathing that are far more significant than having this argument about teeth and dental development. I sort of do the reverse of what I did at the beginning. I wouldn't, I'm going to put that at the bottom of the list of things that I would even come around to mentioning if I was to look at it from a health perspective. So what is the issue with mouth breathing? Well, it's what I showed you guys before in those other slides. It's cardiac, it's cardiovascular. Also, it's cardiac, it's vascular. It's neurological. I've just mentioned the heart, the brain, and the blood vessels. They are three big organ body systems that are pretty important for your long-term health and well-being. Now, without being disparaging, because you know that I love you both and trust that that you understand where I'm coming from here. Who cares about teeth compared to the heart? Who cares about teeth compared to the brain? Let's go big picture here. We can get our tunnel vision, and I'm not undermining anything you guys do and what's important. I think you understand that. But let's just put things in a pecking order for a moment. Brain damage versus crooked teeth. Where's a parent going to be on that spectrum of concern? I'm going brain damage. Now, what are they going to be aware of? They're going to be aware of crooked teeth. They're not aware of the brain damage, okay? Because they don't, live in the worlds that we live in and understand the things that we understand. They're just going to see a child that's having learning problems and behavior problems and struggling through life, not realizing that is a manifestation of brain function, which is then a secondary manifestation of the fact that the child is not breathing properly, which is then tying in with the fact that they're not sleeping properly. So, but they'll see the crooked teeth, all right? They won't see the brain damage, okay? But that's where we shine the light on that being the case. So why is mouth breathing a problem? Well, look, mouth breathing is good if it's keeping you alive, and you get that thing is like, well, if you're mouth breathing, then you're alive, what's the problem? And you go, all right, I'll take that as a relative statement of fact that is reasonable. Yeah, all right, you're right, it's keeping you alive. But there's something going wrong in terms of what you're doing to survive. It's like saying, you can live off of junk food. Yeah, you can. But is that a healthy, sustainable, good way to live? Clearly not. So mouth breathing is the same. Mouth breathing is kind of like junk breathing. It's good. It's keeping you going.
I like that.
But there's problems tied in with this, okay? And the problems are if you're mouth breathing, it changes the way that you breathe, not just by virtue of the hole that you're breathing to, but the way that you breathe. But you actually breathing using what we call the accessory muscles of breathing. So you're breathing up more towards the upper chest as opposed to nasal breathing, which is more about what we call diaphragmatic breathing. So your diaphragm is the muscle at the base of your chest cavity that when it contracts, it pulls the whole lungs down and draws most of the air into the bottom part of the lungs, relatively speaking. And why is that important? Because most of the blood flows through the bottom part of your lungs. So the importance is what we call in medicine is ventilation to perfusion. So ventilation is where the air is going in and out of, and perfusion is where the blood is flowing through. And we want to match that up as best we can, because the more we match it up, the better gas exchanges we get. And the better the gas exchange is, the better you're breathing. The knock-on effect then is the better your oxygen level and the better that your heart can work. When you start mouth breathing and the air is diverted towards the top part of the lungs, that means that you're actually missing out on getting the full benefit of that dose of oxygen that your body went to the trouble of sucking in, which means that your oxygen level in your blood is slightly lower. And in children, that's significant. Children are far more vulnerable to slight drops in oxygen than adults are. So if in a child, the oxygen drop doesn't sound like much, 2-3% on mouth breathing, but for a child, that is significant. Because the oxygen is lower, but the organ body tissue demand is the same, the heart has to deliver a greater volume of blood per minute to compensate for that. So the heart has to work harder. In doing so, it is squeezing and squashing and pushing harder. In doing so, that is putting more pressure then into the blood vessels, which means that they are going to starting to stiffen up slowly but surely over time. And there you have it. You've got a breathing problem, you've got a heart problem, and you've got a vascular problem. How does that relate to the brain? Well, the brain kind of needs some very important things. Its basic things are to keep a brain going. It needs sugar. Okay, it needs glucose. It can run off other things as a substitute, but glucose by and far is its number one preference. It needs oxygen, and it actually needs sleep. And what do you miss out on when you're mouth breathing? Well, you miss out on a bit of oxygen, you miss out on a bit of sleep. And there's a whole lot of endocrinology that you're actually missing out on, a bit of sugar too, but let's just go big picture here as well. So you have a scenario then where, as I said, without being disparaging about the teeth, I've just highlighted brain damage, cardiac remodeling, and vascular disease, which are major killers of things. Now, did people die of crooked teeth? I reckon that'd be a stretch to find, a big number. Do they, want straight teeth? Of course they do. That's just part of what's out there in the zeitgeist of things. But if you were to give people an explanation of mouth breathing from a medical point of view, they are the things I would be highlighting, okay? And then we can sort of go down to the gut. I'm not even getting to the jaw yet in the teeth. We go to the gut. We know that these low oxygen levels changes the gut. And we're still in our infancy learning of just what that all means. But there's of gut bacteria and the blend and the makeup of the same, and how it seems to interrelate to a whole host of things. And what we're realizing is that the gut bacteria makeup mediates the effect of obstructive sleep apnea on vascular disease. They're learning that it mediates mental health conditions. We're learning about the gut-brain axis. And mouth breathing, well, I just chopped that one then too. We've just interfered with those dynamics as well. So that's another big organ system that we just affected. And then if we want to bring it around, because, obviously this is I'm guessing predominantly a dental audience that you've got. So let's bring it down to that level. What does the mouth breathing do? Well, it changes the bacterial makeup in the oral cavity, and we're just learning more about what that sort of means. But tied in with that and dryness, we know that we have an increased risk of dental caries. Mouth breathing is a higher risk for early dental caries than poor oral hygiene is. That's how bad mouth breathing is for you. Okay, so we got that. Gingival disease, it goes up with mouth breathing. And then if you want to have the argument about does it affect how the jaws grow, well, like I said, slide 2. By the time I've got to this, it doesn't matter. It doesn't matter if it has an effect or not in terms of whether this child has crooked teeth or not. Does it change the fact the kid has got crooked teeth? No. They've got crooked teeth. It's there. As to how it got there and why it got there, why are we even having the argument? Does it change the fact that it's there? No. Does having mouth breathing have an impact on this child's health? Yes. Does it matter if the health and the teeth are interrelated because of the mouth breathing? Not anymore, because we're dealing with the whole patient. And if you're going to be dismissive of mouth breathing because it doesn't, because you want to believe, that's okay. Sometimes we live in religion here. If you want to believe that mouth breathing doesn't cause jaw problems, I'm not going to have an argument with you. I don't care. It still causes all the brain problems. It still causes all the cardiac problems. It still causes all the vascular problems. It still causes all the other things I can list off as a medical person. And if you want to talk about negligence, all right, if you want to say, it's negligent to treat a child early, it's negligent to dismiss a mouth-breathing child. That's a greater level of negligence right there.
Yep. It was beautifully stated. And I'll let that transition right to Bill on what can we do about it? in the dental orthodontic arena when you see these patients come in? Because I just had an article published in OrthoTown on this that they were kind enough to put on the cover, which is great in the effect of not from an egoic perspective, from a realization that this is actually starting to become more commonplace to have these discussions. And it'll be what we're going to finish the talk with next on the difference in that was mainly the gist was it's not all about OSA, right? There's a lot we do with that. We're missing the boat here to just talk about OSA in these kids. We've barely even talked about that to date in this or to this time in this episode. But from an orthodontic perspective, our colleagues, the AO white paper clearly states that you should be screening for airway every patient. American Academy of Pediatric Dentistry calls for it in their position statement. The ADA calls for it in their position statement. Yet I would be willing to venture, and I've asked guests this on this show, the general consensus is probably fewer than 5% of our orthodontic colleagues are actually screening for airway. What do we do as orthodontists to get our colleagues to understand the importance of this and why it should be on our radar?
Well, we changed the name from the American Association of Orthodontists to the American Association of Orthodontists and Dental-Facial Orthopedics. Our journal has that. And so David's right. I mean, it's dental-facial orthopedics. It comes in second in the list, but, I don't know how all that started, but basically some wise people back in the day said, hey, we're not just orthodontist, straight teeth. We are dental-facial orthopedist is probably maybe a better term. And then that brings in expansion and all that more. But part of the problem that I think we have in orthodontics, unfortunately, it's kind of the way our educational system has grown. Residents are there for 3 years, 2 years, some. I think most of them now 3 years. And part of that is to learn how to move teeth. Okay, that's what they're there for. I mean, orthodontist. But they're there for 3 years, and one of the criteria for that is they want them to see cases and start to finish. They want to see how teeth move over time and parallel roots and get all this stuff just right, whatnot. So the problem is that the educational system doesn't lend itself to early treatment.
Yes.
There were some orthodontic programs that kind of tried to do that, but it was kind of, and I think that's where some of the traditional orthodontics came from was, you don't get it. If you don't get it in school, it's almost like I was not taught that. So therefore, I'm not going to go learn about that because I was not taught that in school. And unfortunately, luckily, and I have to brag, I guess, me being at UAB, they've embraced that. We have a whole lecture series on sleep disordered breathing. David knows, I told a few weeks ago, Kirk Withrow, who is a otolaryngologist at UAB. I'll brag on him. He's one of the first ones to do Inspire. Okay. He was probably one of the first in the world to do Inspire treatment. And he gave us a talk on Inspire. Of course, that's end stage.
Right.
That's, obstructive sleep apnea, CPAP, oral appliance therapy in adults, Inspire, all those things are after they've been diagnosed with obstructive sleep apnea. We can talk about the other sleep disorders. Well, let's just talk about obstructive because that's what we're talking about. It's how it relates to what we're doing as orthodontists. The structural framework, and David is exactly right. All these other medical issues take top priority. Now, we just happen to be in the realm that there are things we can do to alter that craniofacial growth that's occurring because of the mouth breathing. Because mouth breathing does change the shape of the face. I mean, that's been proven a lot of different ways.
And it's not just in Harvard studies, which are great in monkeys. There are numerous studies in humans, many of them in the AJODO over the years. Breslin and Hune, and there's been a ton of, there's a lot. So,
Linda Aronson about adenoids and tonsils and all that kind of stuff. And Bob Ricketts was one of the first orthodontists to start looking at the frontal, because he kind of helped, and then Dwayne Drummond's came on the scene and kind of refined that a little bit about that frontal 2D analysis, which is great. But when you start adding 3D into it, it makes it a whole nother. Luckily, I got to spend some time with Bob Ricketts, and especially with Dwayne. I spent a lot of time with him. But luckily, Carl Gugino, kind of brought cone beam CT over to the United States. Carl was an Italian, and then he knew Yvonne Deuce, and then I actually got to see the first output of cone beam CT in 1996 with David Hatcher at a Black Curtain event that we had at an AAO meeting. And I was looking at scrambled eggs. David Hatcher was just going freaky. He was going, oh my gosh, this is going to change the world. And we were looking at 8-bit images, but he could see the value of it. So it was like, now you can start seeing the anatomical truth of the patient. And that's why I take it. People say, do you take cone beam CT on all your patients? And the answer, I do.
Same.
Because if I don't, I'm going to miss something. And that's what I'm trying to stress to the resident stuff. We take the lateral and frontal ceph. I'm looking at things. I'm going, talking to the patient, which, because I bring up Airway. I see you see the dark circles under their eyes. You see their mouth breathing, whatever you might see clinically.
They're bouncing in and out of your chair and running around the room. And
well, they're running, the young kid, they're bouncing off the walls and stuff. And you just kind of start asking questions. How well does your child sleep? Well, they don't really sleep that well. Do they go to sleep at night, sleep 8 or 10, 12 hours and still wake up tired and grumpy? Yeah. Do they have, I don't really get into ADHD, that designation per se, but behavioral issues. You can kind of tell that when they're just sitting there in the chair. And there's a lot of things that you can do clinically, just a clinical observation of these patients.
Nothing to do with the teeth at that point.
Nothing to do with the teeth. And David's right. It's bottom line, the teeth are the lowest part on the totem pole, even though the things that we can do to the facial structure and restructuring that allows for more volumes. Just because you got a bigger volume doesn't mean the flow is better. It's like taking a hose pipe and you got the little hose and you're squirting and water in your yard, and you go, well, let me go to the fire department and get a bigger hose. And then you turn on the thing and it's dribbling out the end. You got a bigger volume, but you got less flow so you have to really turn up that pressure to make the same amount. So, volume and flow we assume. And here's the other problem. We, even if we take cone beam, we're looking at pharyngeal area. And even in a lateral ceph, we look at a lateral ceph, we can see maybe tonsils and adenoids and things like that. But we look at that, look at the pharyngeal area and say, hey, their airway looks good, but we don't think about this.
In the nose,
And this is what's so, in my mind as an orthodontist, and the reason I take cone beam for a couple of main reasons, but one of them is I want to see the transverse dimension, and I want to look at the nose, because I'm, like David said, I'm finding at least 30% and probably more than that of issues in the nose, deviated septums, large turbinates, narrowness to that area. The orthodontist ought to look at the nose.
I agree.
First.
It's such an important part of it. And we it's like we're scared of it, and we know the anatomy. We study. It's not rocket science. I mean, it's not to just do a basic, as David was saying before, screening of the area. It's not like you're diagnosing them with allergic rhinitis. You just notice that this kid has really dark circles under their eyes, and that's a sign of atopy and is directly correlated with an increased incidence of allergic rhinitis. So you tell the parents that there are things in here that in Johnny that I can see that tell me it's really hard for Johnny to breathe through his nose. Not only are you telling me Johnny can't breathe through his nose much and walks around with his mouth open, or when he's playing video games or when he's sitting doing homework or reading, his mouth is wide open, that he snores at night, et cetera, et cetera. But what I'm seeing on this image is consistent with that. So I feel Johnny should go see my allergy colleague because I think there could be something there and I would like that investigated. This isn't complicated. And when I teach residents this, the residents completely get it. It's the faculty that don't.
Because they've not been trained in that. They've not been exposed to it. And we're not doing cone beams on every patient at the school just because, but when I get a patient and I'm looking, that's one of the first things I'd say is especially if I start seeing some signs, I go, let's get a cone beam. We just got a new cone beam called the Ray Scan, and it has the software that I use. So I'm excited about that. That just got installed. So now we're going to start using it more because when I see the patients that I've got to be responsible for, the residents know I want a cone beam CT. They can take the lateral ceph and the pan for their purposes, but to me, that's just a waste of. You talk about a waste of X-ray radiation.
They're very fortunate to have you, and you're very fortunate to have a director and a chair that are supportive of that, because that is not the case in most places. I can speak to that from personal experience.
It's really great because we're getting that, and they can see. Because what I try to show is, okay, here is a young 5 or 6 year old patient. Maybe we don't have the way to do it in the clinic per se. We are starting to see them earlier because of that.
We're starting
to do some earlier.
I work with the residents at Montefiore. It's an amazing program where they're doing some great things. Mirage, their director, is amazing, and they're starting to see helping them virtually with a lot of these cases, and they're seeing these kids young. And they said just what you said, Bill. They start seeing more of them all of a sudden.
All of a sudden, if you start looking at that, the problem is we can't see the forest for the trees because we're kind of limited in what we do. Once you start to do that, once you start using cone beam and you really start looking at that, and people that are kind of scared of it, like you said earlier, some people are coming to me, well, it's too much information. I don't want to be responsible for all this stuff. Get it read by radiologists. There's Dale Miles out there. There's the Hatcher Group. There's Danny Tamimi. There's a lot of those oral maxillofacial radiologists. That's what they do, and they will give you a report. And the good thing, what I'm trying to do is do that and look through the cone beam and stroll through there and say, I send them to the ENT and go, hey, look, here's some images. Here's the DICOM. Look at it yourself, and you tell me what you got to do. At least, and the screening part too, the American Dental Association through Steve Karstensen, who's in Seattle, he's a general dentist that basically deals mostly with adult patients that are CPAP intolerant.
Steve and Jerry Simmons did a joint episode with Steve and Jerry a little while back. That was great.
And Jerry, we've got this committee, I'm part of it, that Children's Airway Screener Task Force, and we've come up with the CGAS, Children's General Airway Screening Protocol. So it's just 5 questions, and it's a little bit of, now Kevin Boyd has us actually measuring some of is it class 2? Is it a distal step in the primary dentition? What's the intermolar, intercanine width? How does that relate? Later, we're going to take a group and have them fill out the form, which is 5 questions, real simple. Any yes answer elicits, hey, you need to have it looked at by an ENT or somebody, because if they check off, yes, your child snores, well, why do they snore? They have restless sleep. They have behavioral issues. They sleep weird. They sleep with their rear end up in the air because they're trying to open up the airway. All those things are simple little questions to ask. And then what we're wanting to do is expand that into doing comparing that to what polysonography would say, because it is the gold standard.
Questionnaire.
It's hard to get it. And then we want to validate what Jerry has is called a sleep image ring. It's different than the Aura ring. He's tweaked the software to come up with not only heart rate variability and oxygen and all that, but cardiopulmonary coupling, which has a little bit correlation to AHI. And Dr. Gimeno and Dr. Dement, who invented AHI, the apnea-hypopnea index, which measures the severity of sleep apnea. They said before they died they wish they'd never done it, because an adult that has 4.9 events per hour is considered not having sleep apnea, and if it's 5.0, they are. And it's never supposed to be done that way. That's what insurance companies have taken. And if it's not over 15, then they won't even pay for certain.
And in kids, it's even worse. And I'm glad you brought that up, because I'm going to let David close it up with a discussion from the medical perspective on the fallacy that is that if a child doesn't have a diagnosed with the PSG diagnosed AHI of 1 or greater, then that child is airway healthy. The end stage disease is obstructive sleep apnea, which is going to be what's detected by polysomnography if it's moderate to severe, likely. But there's all these kids in the, whether it's obstructive hypoventilation or upper airway resistance syndrome or just primary snoring, that are along that gradient, but not there yet. So if you could just kind of tie it all up by parsing that together.
Yep. So, I mean, gosh, we could do another hour just on the history of sleep studies. Sleep studies have emerged and evolved as the technology, as the tools, as the measuring devices got better. But I'll talk about diabetes for a sec, just to explain how we sort of got here. So with diabetes, they did a huge population-based study to look at different levels of blood sugar, to then say, at what point does your blood sugar level get to that increases your risk of having high blood sugar? And they looked at things, like vascular disease in particular, having heart attacks, having strokes, losing your limbs, that sort of thing. And they did a population-based epidemiology, mathematical thing where they said, from this one onwards, you're at risk. And they said, but before you get to that, we have what's called pre-diabetes. And the nice thing is you can pick this all up on a blood test, piece of cake, and you can do it either as a fasting or what's called a glucose challenge. So we have different numbers depending on how we're measuring this, random, all that sort of stuff. So they did the math on that, easy. Now, the reason I bring that up is that when we come to the AHI, if you hadn't yet noticed, there's a very convenient, remarkable thing about the numbers: 5, 10, 15, 20, 30. Now, what's remarkable about those numbers is they are round numbers, okay? How did they actually come to those numbers being lines in the sand? They didn't. They were just nice, round numbers. And the original numbers were a lot higher than where we're at. And as the technology came along, they were finding even more and more of these events, and they had to sort of just reconfigure and just work out, things, because, well, gosh, we're finding a lot more disease now. Well, let's just pull those numbers back. So those numbers are not based on epidemiology in terms of risk consequence of having obstructive sleep apnea. Okay, they are just convenient, nice round numbers. I can remember way back in the day, and I keep trying to find this paper and I can't, but someone, way before we had any sort of like the AI that we appreciate now, somebody that was a mathematician actually stood back from it all and said, hey, at what point does the actual risk, things like heart attacks, strokes, etc., that we're talking about, are risk consequences of obstructive sleep apnea in adults, at what AHI does that actually mathematically kick in, just like they did with the diabetes? And it was about 3.4.
Really?
From memory. Okay. 3.4. Okay. Wow. When you actually looked at it and say, look, if we want to keep using these things.
And that's in adults, right? For that?
This is in adults. I'm only stuck on adults at the moment. So the problem then was, I did the math, 3.4 adults, etc., in terms of where your risks lie and just building on that. But then the next problem that we have is when it came to kids. Now, what we had in kids was we had this real dilemma because historically, if you go back to the 1910s, 1920s, the number one reason listed in the old books back in the day for taking tonsils out was snoring. Wasn't infection, it was snoring. Okay? Now, infection was on the list, tonsillitis, and then what happened in the 30s? Penicillin. What happened? Tonsillitis could be fixed. What happened? No more surgery because don't need to take tonsils out for infection. Overflow, don't need to take it out for anything else either. Consequence, sleep apnea rocks up in the 70s and the 80s. Here we are. Here we go.
I had no idea about that. That's the first I've ever heard that. That's amazing.
History is a great teacher.
Yeah.
So what happens is that in the 70s and the 80s, all right, Christian Gimelo comes on the scene and, hey, we've got this thing called sleep apnea that we're dealing with. Now, full credit to where it's due for the pioneer and everything that he was, but rewind 100 years ago, he wasn't the pioneer. It's all there back in the day as well. It's just that, it was turning up in adults and so forth. And then we fast forward to the 90s when we start going, hey, we're starting to see that these kids are like stopping breathing. Like we've had this thing about all the adults, but these kids are stopping breathing. Maybe we should start measuring their sleep as well. So we did. We started doing sleep studies. And what numbers did we use? 5, 10. We used adult numbers, okay? So your original historical numbers that we used in kids were based on adult numbers. And those adult numbers were totally made up. Totally made up. There's nothing about it that was correlated to disease outcomes. We're now trying to correlate the disease outcomes to the numbers, and we're seeing it's really hit and miss. It's because those numbers are made up. They are convenient, round numbers for human brains.
And for insurance purposes. They're convenient numbers for billing purposes. I hate to be cynical, but
they are numbers of convenience. They are not numbers of medicine.
Yeah.
So that's a really important thing just to reflect on. Apart from the validity or otherwise of the actual thing in the first place, the numbers that we're using are totally made up. And then so we use the same numbers in children, but we realize that, hey, we can see these children are stopping breathing and having problems, but they might be doing it once an hour as opposed to 5 times an hour. So let's change the number to 1. So 1 or more became the number, okay, for sleep apnea, all right? Now, this is primarily driven by the medical care, all right? We have people like me that are surgeons, which, as I said, we don't have much evidence base to what we do. But we have physicians, medication, very evidence-based in terms of their foundations, randomized controlled trials, and measuring and putting numbers on things, okay? So from their point of view, the sleep study was putting a number on something, okay? And it was only putting a number because of what we were measuring in kids. It was only putting a number on obstructions, okay? And we have like complete and partial obstructions. That's where the AHI comes from. The A is the apnea and the H is the hypopnea. And then we start measuring, the hypopnea. It became a real problem because as the measurement tools became more sophisticated, we found more and more of them. And then we're sort of like, and then we started adjusting, how much of the airflow had to be restricted to be counted as a hypopnea. And then if you talk to Jerry Simmons, he's banging your head against the wall because there's now 2 directives you've got in the USA as to whether you use 3 or 4% oxygen drop to score it as a hypopnea. And whether you use 3 or 4% has a huge difference in terms of which children do or do not land into the diagnostic category of obstructive sleep apnea. And then Jerry's other thing, which he's absolutely right, is that, that's just sleep apnea, upper airways resistance syndrome. If you're going to do that properly, you need to do esophageal manometry. That's putting a little tube down the nose in through the night to measure that as well, which most sleep clinics don't do. And then I've gone through the whole evolution where snoring is normal. And then we said, primary snoring was basically a term medically that meant that it was snoring, but there was nothing to worry about. Turns out there was. Any kids that are snoring 4 nights of the week or more are having issues. And then we land on the mouth breathing thing. So that is the sleep disordered breathing spectrum. And we have a tool called a PSG, or a sleep study, that can pick up 10% of that spectrum. Because that 10% of that spectrum we call obstructive sleep apnea. That's the thing that we can put with confidence a number on to then justify a clinical diagnosis.
But it doesn't mean that 90% are healthy, right?
At the same time, we're saying the other 90% in that spectrum are perfectly okay.
Yeah.
So if we take 100 kids and we do a sleep study, we haven't screened them for anything, we take 100 kids, just a population sample, playing a numbers game, we will find 3 out of those 100 kids, or thereabouts, 2 or 3, will have obstructive sleep apnea. 17 to 18 of them will have sleep disordered breathing that we just walked past because we only relied on one tool for thinking, which was a tool that can measure a number. We did not look at history. We did not look at examination. We looked purely at an investigation outcome. Now, my medical training, which I think, is still pretty reasonable in terms of its approach, the reason you do an investigation is because it will change your management. Okay? So if I have a child, the parents come in, they're not breathing properly, they're not sleeping properly, I look inside, I see big whatever. How does measuring this change my management? And if it doesn't, I don't do it. Because I don't need a number on a piece of paper to tell me this child's got a problem. I can tell this child's got a problem. And, these day and age, I get the parents to take a video. And I'm showing my age. I literally lived through all these changes. All these changes. I can remember, the ENT going, hey, they've just changed the number on the AHI for kids to 1. I can remember that. And I can remember when we changed the sleep apnea measurement numbers because we had more sophisticated ways of measuring airflow. We went from thermistors, which was basically measuring the temperature as a means of measuring what the airflow was, to a pressure transducer. Now, when you did that, you found a whole lot more airway compromise than you ever knew about to start with. So anyway, a normal sleep study does not mean normal breathing. Full stop. That is as simple as that. I will, I can literally count on my fingers and toes in the past 20 odd years as being an ENT primarily focused on sleep disordered breathing, where I have felt I needed a sleep study to work out what was going on because clinically it did not make sense. And most of the time I'm semi-hoping and praying to the ENT gods that sleep study is going to come back showing this kid's got sleep apnea, so I can actually help this child in a scenario where the parents are absolutely convinced there's nothing wrong with their child. So, in the past 20 odd years, fingers and toes and then some left over where I have needed a sleep study to help me work out what's going on. Good history, a good exam, and these days with a phone video thing of the same, and off we go.
Thank you for explaining that. And I know it was said last point, but for this, and you don't have to go into great detail on this, but just your opinion on this, then why, knowing all of that, why, and I love the history, by the way, I think that is so relevant and important to put out. Why does so much of the literature that comes out of the orthodontic arena base anything and everything we do on a change in AHI? It is fundamentally flawed, right? I mean,
it's because we can measure it, and I've had these discussions. I've been at big ENT conferences, and I'm, pardon my French, I'm a pain in the ass when I'm at these conferences. Okay,
I've been accused of being similar.
because I ask those questions. So in the US, you've got the CHAT study, which was a $10 million US study where they looked at no intervention. They're trying to do the randomized. Let's not treat, let's treat, and they used the sleep study parameters as their measurement outcome of getting better. And I asked the question, said, why are we doing this when we know that it doesn't look for sleep disordered breathing? And the answer was, well, look, we know that, but it's the best we've got, so it's what we stick to. And that actually is the problem. Okay, we know that we have a measurement tool. We know all of its shortcomings, all of its flaws, all of its issues. And by the way, even just using that, You need to do it for 3 or 4 nights if you're going to get anything that's representative as well, which we don't do. So not only do we have a bad tool, we use it poorly. Okay, we use it inadequately, and why? Because we don't have anything better. That is the big number one answer, is that because we don't have anything else to go to, and we're so hell-bent on the idea that we have to have some way of measuring it, we would rather keep a bad tool with bad numbers than have nothing at all.
Yeah.
That's basically what it comes down to. And then part of the problem that you have in your country, which I don't have in mine, but in your country, is that your health system is run by insurance companies first and doctors second. And depending on which insurance company you're talking about, if you have a child that needs their tonsils and adenoids out for airway problems, there can be a mandate that says they have to have had a sleep study showing that they've got sleep apnea before they meet the insurer's criteria for care. Now, the insurer's criteria for care is not the same as what a medical doctor's might be, but obviously we come down to money and finances and things, and you don't live in a cheap country when it comes to accessing healthcare. So having insurance pay makes a big difference in the big scheme of things. So I understand that. But let's look at those numbers that I showed you, Mike, when I ran those numbers and algorithms on the CBCT and finding those kids and fixing those kids early versus not at all in health outcomes. Your insurers in their big projections could be saving themselves billions of dollars by opening the door to getting these kids in early and getting them fixed, rather than picking up the consequences of obstructive sleep apnea in adults, cancers in adults, etc., and so forth.
If anyone's got a direct line to RFKJ out there listening and can get this in front of,
we're trying to get this in front of
we're about what are we at the moment, Bill? About 2 degrees of separation from RFK.
Yep. Not two. Yeah, we're close. We're pretty almost direct.
We're down the corridor, but not knocking on the door yet, Mike.
Okay. Well, if there's anything I can do to help, I'm happy to, because I do believe everything we've talked about today, which has just been absolutely amazing. And I just can't even explain how much I appreciate both of your expertise and insight and knowledge and ability to communicate these things and be honest and open. It's just such a blessing to know you and be friends with you and have you come on the show and share this. I really, really do appreciate it. And I really feel that this has shed a lot of light on these topics in dark places that we don't like to go, that aren't super comfortable to go, that we don't go to in our meetings and our 45-minute talks that we give. And look, I'm giving some of those talks. I give those myself, so I'm not pointing fingers, but this really let us dive deep into the undercurrent that is existing here in this challenge we face. And unfortunately, and I don't think it's being overly skeptical, I feel like, and you said as much, David, it does come down to the money. And I feel like if we could start to help the healthcare system understand that if we recognize this earlier, right, much as they're trying to do in other arenas, which is why I brought up the MAHA movement and RFKJ, is if we can get to these things younger and earlier, you will save money, a lot of it, probably magnitudes of billions and billions and trillions, and saving lives and improving everybody's quality of life, their health span, not just their lifespan. So this is really, it's kind of yeoman's work, but this needs to be done. And I really appreciate you both fighting this fight, because it's not an easy fight. And I feel the pendulum starting to shift.
And one of the things that I would love to see when RFK is up there talking is not just about nutrition and exercise, because that seems to be the focus: nutrition, pharmaceutical, exercise. In my mind, it needs to be breathing first, then eating second, sleep's third, and exercise or motion is fourth, and kind of in that order, because without breathing and proper breathing and all that, the rest of it doesn't matter.
Yeah, it's true. It's true.
So I'm hoping if anybody's got any kind of access to HHS or whatever, that would be my thing, is to hopefully get up there and say, okay, it's breathing first. It's eating second, because that's what you do. You're born and you breathe, then you eat, and then you sleep, and then you start moving around. I mean, it's kind of in that order if we could make that happen. But anyway.
And Mike, you asked if there's anything you can do to help. So this is the last throwaway line. Anyone that knows Taylor Swift, we just need one post from her. Yep. One post from Taylor Swift. Seriously, Mike. One post.
Yep. Seriously.
Taylor Swift.
Yep.
And this all goes away.
Yeah.
Because every single mother is going to hear about this.
Yep.
Give or take a couple of million here or there. And then that's the reality. The message is, it's just one big moment like that away.
Yeah.
And all of these walls disappear.
Yeah.
So to answer your question, anyone out there that knows Taylor Swift, just nudge her a little bit and just say, hey, look, this may not be on your radar, but maybe you're going to have children one day. Mm-hmm. Maybe you want to have them growing up, breathing and sleeping well, because there's a 20% chance that they won't.
Yeah. Yeah. And I say it all the time to people, but share the show, share it with people. This was a ton of invaluable information that was offered here. You never know whose ears it's going to fall on when you share it and they share it and they share it. These things can go viral. And if it falls into the right hands or ears, so to speak, that can be the golden key that unlocks the door to get this message out there, because we have all the evidence, we have all the data, we have so many brilliant people such as yourselves able to speak articulately on this. We just need to get in front of the right people. And I really do believe once we do, we are, to your point with Taylor Swift, once that hits home with the right population, it's going to change everything.
Change the world.
Well, thank you both so much. If you want to get in touch with you, how can they? If they have some follow-up questions, or if they want to reach you or contact you?
You track me down on Facebook and Instagram. The sort of the way things do. I'm not on TikTok. I haven't got my head around that one. So
Same. Yep.
They could actually email me as fine. It's Dr. Harrell, DrHarrell at AOL.com. It's probably the easiest one. I've had that one forever.
Okay, perfect. Well,
but I am on Facebook. You can look up Harrell Orthodontics or even Bill Harrell. I think I've got a couple of Facebook.
I'll put links to those contacts in the show notes. And again, I can't thank you both enough, Dr. Bill Harrell, Dr. David McIntosh. It's an absolute pleasure, and really my sincere gratitude for coming on the show and sharing so much of your knowledge.
Mike, thanks for having the show that we can share it.
Yeah, my pleasure. All right, bye guys.
Take care.
Thank you. Bye-bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.